All attendees are in listen-only mode.
Good afternoon. Today's webinar will be 55 minutes. Hopefully we'll have time to answer questions at the end of the webinar. This is over 20 webinars that we've presented in 2016. And just for information, the webinar and the slides will be posted on our website probably tomorrow or the next day. Just to give you an update before we start our session, we are preparing for the next 5-year renewal, and we're actively looking for researchers to discuss with their faculties and departments to see if there's an interest in the universities to support partnerships for fellowships or any KT initiatives in the next 5 years starting 2017. So we will be sending out some follow-up information to your universities, and if anybody's interested, please contact Jackie St. Pierre or myself, Carol Berry, and we would be happy to follow up with whoever it is that you want to have us have this discussion with. Right now we have a video contest. It has just opened, and we're looking at videos to determine what frailty means to you. The early bird contest closes April 28th, and the final one is May 5th. Please look online for additional information regarding this video contest. Watch also for our newsletter, which will be coming out shortly, which will give you an update on projects that have been funded, new trainees, and other important information about network members. Just as a reminder, the annual progress reports for the research projects and our fellows are due April 29th, 2016, so we can report to NCE. There will be a question and answer at the end. Hopefully it'll be 10-15 minutes. Please submit your questions using either the chat function or the question function that you'll see online as you're watching the GoToWebinar. We'll try to answer as many as possible. And so the presenters today, we are lucky enough to have 2 of them. We have Rick Sawatzky. He's a Canada Research Chair in Patient-Reported Outcomes. He's a research scientist with the Centre for Health Evaluation and Outcome Sciences at Providence Healthcare, and his clinical background is in palliative care and medical nursing care. We also have another presenter. I'll hopefully say this right, Kara. It's Kara Schick-Makaroff, and she's from the Faculty of Nursing at the University of Alberta. She completed her master's and PhD at the University of Victoria, and her research interests are centered upon enhancement of quality of life for people living with chronic and life-threatening illnesses. And so I'll turn it over to you now, Rick, to start the presentation.
Excellent. Thank you very much. Thanks for the introduction, and thanks everyone for joining this webinar. We're going to be talking about an electronic quality of life and practice support system for patient-centered older adult care. And really appreciate you taking time to join us during your busy schedules. Like Carol said, I'm Rick Sawatzky, and I'll be one of the presenters together with Kara Schick-Makaroff. We'll just introduce each other shortly. Before I do so, I'd just like to say that we do welcome discussion, and I believe it's possible for you to write questions in a little chat box, and that those questions would then be presented to us at the end of the presentation. So we won't have discussion during the presentation, but we are going to do our very best to leave ample of time for discussion after the presentation. So please note your questions as we go along. So like I said, I'm Rick Sawatzky, and let me just see here. So I'm Rick Sawatzky, and I lead a program of research funded by my Canada Research Chair at Trinity Western University, focusing on patient-reported outcomes. And part of this program of research involves the examining what we refer to as a quality of life assessment and practice support system. And this is about bringing the quality of life concerns and the priorities and needs and experiences of patients, older adult patients, and the family caregivers at the forefront of the care that we provide. I lead 3 CHR-funded research initiatives, one that focuses on this system, another that focuses on statistical methods for patient-reported outcomes, and another one that is a partnership with the BC government and the Canadian Institutes for Health Information that focuses on the selection and utilization for patient-reported outcomes. So, Cara, I'll let you introduce yourself.
Great, thanks, Rick. So, I started working with Rick and this team on the projects that we're going to be talking about today during the time that I was a postdoctoral fellow, and I was particularly involved in the qualitative analysis that we'll be talking about. And as Carol mentioned, I'm now at the University of Alberta. I'm a new assistant professor in the Faculty of Nursing, and my research really centers around quality of life for people living with life-limiting illnesses, and I have a particular interest in the routine use of electronic patient-reported outcomes in clinical practice. So that's all I'll say about that. I'll pass it back to Rick now.
Great, thanks, Cara. So what we're going to be talking about today is a larger initiative that includes 2 projects funded by the Canadian Frailty Network, as well as some projects funded by CIHR. But we're going to be focusing on the Canadian Frailty Network projects, and this involves quite a large team, and that's part of what we want to bring across today, is that this type of integration of patient-reported outcomes and quality of life assessment instruments in practice involves quite a multi-partnered and multi-layered type of collaboration. And so we have 3 principal investigators, myself and Cara, and also Robin Cohen at the University of McGill and Kelly Stadler at the University of Victoria. We have a bunch of co-investigators. I'm not going to name them all, and I apologize for that, where there's many co-investigators. And we also have industry partners that I'll be talking about soon. James Voth, who is founder and director of Integrate, and Bruce Ford, who is the CEO of Cambian, which is an electronic health information integration company. We also have administrators and clinicians on the team, Dr. Hilliard and Carolyn Taylor, directors of end-of-life care at Fraser Health, and several clinicians and decision makers from several health authorities. The project involves a patient and family caregivers panel, as well as a list of highly qualified personnel that have accumulated throughout the years, and so you could see their names over there. For sake of time, I'll just move along. Like I said, the work involves various layers of partnerships, and I just want to acknowledge them. One are the health services partnerships, the health authorities. Our primary partner is Fraser Health, but we're also working with Island Health and Alberta Health Services, as well as with the B3 Ministry of Patient-Centered Measurement Working Committee. We also partner with professional and community associations, including Canadian Virtual Hospice, Canadian Association of Palliative of Retired People, the Family Caregivers of British Columbia, and also Canadian Hospice Palliative Care Association. Apologies that that isn't mentioned there, but they're also a strong partner in this work. And we have industry partners that I mentioned already before. We ourselves don't have any conflict of interest to declare, and so that's important to point out. But like a lot of this research, it does occur in partnerships, and of course the partners do have various vested interest in the studies, and so that needs to be kept in mind. So for today, we've outlined our presentation as followed. I've done the introduction already. Then I'm going to give a brief background on what we refer to as quality of life assessment in clinical practice. We're then going to give a brief demonstration of the QPSS system that James Voss has developed. And Kara Schick-Makaroff is then going to present on our two projects funded by the Canadian Frailty Network that you could see over here. They've both just recently been completed. And then after that, we'll have a brief discussion. Moving along. So the initiative is really focused on getting at the following question, and that is, how do we ensure that the care we provide is both informed by and makes a difference to what really matters to individual people? And the people that who we are talking about here are the frail elderly and their family caregivers. So basically, the projects or the initiatives is working at building blocks for person-centered care. At the very heart of person-centered care lies a notion of finding out what each patient wants, needs, and experiences in our healthcare system. That's, of course, not the only focus, but it is an important focus. And so this involves finding out what the experiences are of patients and families and what the experiences or outcomes are of patients and families. And we've done quite well in using patient-centered performance indicators to get a patient and family experience. And such indicators include wait times and readmission rates and healthcare utilization type of things. We've also done very well in terms of using clinical outcomes. But our healthcare system is somewhat limited in currently systematically, routinely, and in a systematic way revealing the needs and concerns and priorities and experiences of patients and family caregivers. And for that, there's increasing interest in using what is referred to as patient and family reported experience instruments and patient and family reported outcome instruments. And so you need both. You need reports from patients and families about how they're doing and what their experiences are, and you need objective clinical indicators and clinical outcomes about how they're doing. And together, those provide a foundation for person-centered care in terms of the type of information that we need to ensure that their needs are being met. So the imperative for person-centered care requires that the full range of healthcare needs relevant to the quality of life of older adults who have life-limiting conditions and their family caregivers is routinely assessed. So how do we do this? Well, one way is to use what we refer to as patient-reported and patient outcome and patient-reported experience measures. I'll just say that I'm using the word patient quite broadly here. I prefer the term person-reported in a sense because it implicitly could include family caregivers, but the term that's used out there is patient-reported. And these are instruments that are meant to provide opportunity for patients to report on their quality of life and their healthcare experiences without prior interpretation by a clinician or any other person. A patient-reported outcomes instruments involves a selection of questions that invites people to look inwardly in terms of how they are doing. And so this may include questions about their functional status, their symptoms, their well-being, their psychological, social, emotional, or even existential well-being. And so people are asked to look inwardly as to how they're doing in those areas and to provide a response to a set of questions. Patient-reported experience measures ask people to look outwardly as to the care that they are receiving and whether that is meeting their needs. And so they are used to assess patient and family experiences with the care provided. I'll provide a few examples here. One example of a patient-reported outcome instrument is the McGill Quality of Life questionnaire by Robin Cohen from McGill. And this questionnaire has recently been revised, and the revised version includes 14 items, and you can see the content of the items here. And they correspond to 4 what is referred to as domains of quality of life: physical, psychological, existential, and relationship domains. And people are asked to respond to questions, those 14 questions, on a scale from 0 to 10, and the direction and anchors of those scales actually vary by question. This information can then be used as a screening tool for clinicians to be informed about priority areas of need from patients' point of view. And the information can also be used for quality improvement, program evaluation, and research purposes. There are similar instruments available for family caregivers. In fact, you might be interested that we've done a review funded by the Canadian Frailty Network. You'll find it online. Regarding the selection of patient-reported outcome and patient-reported experience measures specifically for frail older adults. And we found nearly 200 instruments that are available out there. So this is just one, but one of the most dominant, widely used examples, specifically in palliative care, and there's others for other contexts of care. There's also patient-reported experience measures, and just as an example, I'm giving here the Canadian Healthcare Evaluation Project questionnaire. What you're seeing here is the light version of the questionnaire, which consists of 20 items. There's a more fulsome version of the questionnaire consisting of more items as well, and there's family caregiver versions as well as a bereavement version. Basically, this questionnaire asks people to respond to questions about their relationships with their provider, their illness management, communication, decision-making, and whether they feel at peace. And people are providing 2 ratings, one about the importance of those areas and one about how satisfied they feel with the care provided in relation to each of those areas. You can see an example over there. There's many reasons for using PROMs and PREMS. I won't go over them in detail right now. I already mentioned healthcare professionals, and we'll come back to that. Of course, it can be used for research services and also by health service decision makers for program evaluation, cost effectiveness, quality improvement initiatives, and so on. And also by healthcare recipients, and we'll come to that in a little bit. There's quite a bit of evidence out there regarding the routine utilization of PROMs and PREMS at points of care. So we're referring to the use of PROMs and PREMS as kind of the groundwork of a quality of life assessment, the initial screening of a quality of life assessment. There's several decades actually of research on this type of idea in various contexts. Including quite a few clinical trials and several systematic reviews, and give some examples of the systematic reviews, recent ones that you may be interested in on the slide here. But overall, there's potential for these instruments to make the concerns of patients and family caregivers more visible, to raise awareness of problems that may otherwise not be identified, to lead to improved clinician communication and care plans, and to facilitate collaboration across healthcare professionals and across sectors of care. Despite this, however, despite the availability of many instruments, they are not widely used in practice. There are several reasons for this, but one has to do with that the instruments until recently were available predominantly in paper form, and it's quite cumbersome to use a paper form instrument that you need to manually score and enter into a chart and so on. And so it is recommended to use an electronic system to facilitate the utilization of these type of instruments. These systems, there's quite a few of them out there, and I give an example of a recent review there by Jensen and Schneider and their team regarding electronic patient-reported outcome systems used in cancer care. So there's quite a few systems out there, and the idea is that they can reduce patient burden, reduce clinician burden. They can help to advance the utilization of that information through effective visualization and monitoring of patient concerns and ongoing feedback mechanisms, and they can become part of administrative data systems, including electronic medical health records. So during the past years, we've been working with James Wass to design a system as part of these and other research projects from a user-centered design point of view. And this system can accommodate just about any quality of life assessment instruments about any PROM and PREMS, so not pre-programmed. It could accommodate other instruments. And it addresses those benefits that were listed on the previous slides, including instantaneous feedback, documentation of interventions, the potential for tracking and assessing where the interventions are making a difference, and the potential to integrate with information systems. So I'm going to move along here. This slide just kind of gives an overview of the initiatives that we have in mind. We're viewing this QPSS as kind of like a complex intervention that's meant to be integrated in practice and that engages a range of target stakeholders, including patients, families, clinicians, and decision makers. The ultimate goal is to enhance person-centered care, shared decision-making, and continuity of care across these various sectors of care that are listed on the right. So, James, I'm going to have you provide a brief demonstration, and I'll just start up the video over here. Just 1 second here. It won't back up. Okay. Well, I don't know why it's not working. We had an online demonstration here, but the system seems to be freezing the webinar system. Let me just try and restart it. Okay. Great.
Hi there. I'm James Wass, and I'm the founder and director of Integrate Research and Development. We've been working with Dr. Sawatzky on the QPSS initiative since its inception, and I've had the pleasure of working with the rest of the QPSS initiative team for some time now. I'm pleased to be able to present this brief demonstration focusing on the point of care component of the QPSS, which is delivered via mobile technologies like tablets. So let's jump right in. For the purposes of this demonstration, I'll be working with a simulator that shows part of the QPSS tablet interface that has been adapted for a brief demonstration like this. Wherever I'm clicking my mouse here, basically what would be happening is that the patient or the family caregiver would actually be tapping with their finger or using a stylus or something like that. So first off, we're kind of starting off with the clinician's interface here. One of the underlying principles behind this basically is clean, simple, and easy to use in sort of an actual clinical workflow. So you'll kind of see that things are quite pared down and very direct and easy to use. Aesthetics are kept to a minimum. They're very nice when you first see them, but again, these are going to be used in a often busy clinical situations. So in this context, we'll just have a quick look here. What we'll do is we're going to find a person that I've already started to create here, and it's already done a couple of administrations of an instrument, one of these PREMS or PROMs, and I'll just kind of go through that with you here. So again, we're looking at the clinician's point of view here on the tablet at this point. So we'll click on Find a Person. They're presented with just sort of a basic search box here, and they can type in and use search on basically any of the aspects of a person that they would want to find. So we're going to look for a gentleman named Mr. Ngozi. Mr. Ngozi, so here we go. You can look by last name. You can look by their nickname if you'd like, by date of birth is available as well, those types of things. And it'll handle misspellings as well, so that's kind of handy. And they'll come up again as well. So we'll just click on Go here and have a look at Mr. Ngozi's file. So again, a very nice simple interface here with a little bit of basic information at the top. This can all be adapted for different clinical contexts as well. We can see their date of birth. And in this case, we have Mr. Ngozi as a patient. You can also enter people and put them with the role of the patient or family caregiver. And what happens here is that underneath this section here, which is the applicable instruments, that would actually change depending on the context, so the clinic and what instruments they've chosen, but also based on the type of person. So there are some of these instruments that are actually adapted specifically for family caregivers. So in that case, of course, only those instruments would show up here in the applicable instruments. In this context here, we can see that about 40 minutes ago, I already completed the e-QOL-R, which is the McGill Quality of Life Revised Patient-Reported Outcome Measure. And of course, in a real situation, we wouldn't be administering it again or asking them to complete it again so quickly. But again, for the purposes of this demonstration, we'll just go with that. So what we'll do here is click New to start a new session of that instrument. And basically it goes into a lockdown mode, and the intent here is to be able to actually hand the tablet over wherever possible to the patient themselves so that they can complete the instrument. One of the basic tenets of patient-reported measures is that we want them to be patient-reported. If at all possible, we want them to be entering the information directly without any assistance or interpretive kind of interpretation from the clinicians or anything of that nature. So again, in case of physical impairment or anything of that nature, they would be able to assist the patient or the family caregiver, but again, we'd want to hand this over. And as we can see, the interface is again very, very simple, set up for people who are not familiar with technology, who are not familiar with tablets, where you can swipe in between the pages. Some people aren't familiar with that, so you can tap on these arrows to go back and forth, which has proven to be quite useful for some individuals. So we're going to not spend too much time on actually looking at this instrument or the questions themselves, but I'll just show you how that works. So they're able to go through the instructions and then be able to just be presented with one large accessible stem or a question per page and then make their responses. They can go back and forth if they would like. If they want to skip questions, again, they can do so. We'll just make some quick responses here and to make our way through this, and we can then look at the results. So I'm basically picking some responses at random, and of course the patient themselves would not be doing so. So let me just move through this relatively quickly, and we can see that we're progressing through, and when they get to the end, they would then hand back the tablet to their healthcare provider or to their clinician in this case. We've kind of excluded the authentication process that would happen between here and going back into the facilitators or the clinician's interface just for the purposes of this demo. But in that case, they would just end that off and we'd be back in the clinician's interface. We can see here now that the e-QOL was ended about a few seconds ago, that I was the facilitator again. And now we have the option to actually review those administrations. So I just tap on there, it connects to the network and loads that up. And with the e-QOL, we can see that we have a couple of things here. We have the individual items that we can look at, which is each of the questions that the patient responded to, along with the raw scores or the raw response that they had. We can see that they didn't answer there and those types of things. We can also look at this in a graphical format, which tends to be quite a lot more useful. This kind of shows trends over time. We're able to see if there's any areas of concern that we might not have otherwise addressed or seen. And we can also use this as a point of validation with the client or the patient to be able to see exactly what's going on or causing some of these things. Here we can see that that we're having a little bit of an issue with the sadness component. They're responding quite low in this context, and we might want to validate with that or see if there's any referrals that can be made to help address that concern. With the e-QOL, we also have summary scores where each of these individual items are actually combined into these different domains or submeasures. So we can see relationships, existential concerns, psychological concerns, physical concerns, and sort of a single item on overall quality of life. The clinician is able to print up these into sort of a chart-friendly format to be able to keep track of these, or also in a format that would be suitable for rounds or things of that nature. So yeah, so that's been a very, very quick demonstration to give you a little bit of an idea from the clinician's perspective and a little bit from the patient or family caregiver's perspective for the point of care aspect of the QPSS platform. Thank you so much for your time, and we'll talk to you later.
Great, good. Hope you found that informative. So thanks very much, James, for that demonstration. and we could field questions later. We'll just move on right now. Kara is going to talk for about 15 minutes about the 2 Catalyst projects that have been funded by the Canadian Frailty Network. So Kara, on to you.
Great, thanks Rick. So I'm now going to discuss the aim, design, and results from across 2 of our CFN-funded research projects using the QPSS, which you just saw, demonstrated by James, and we use these in acute palliative care and palliative home care. So the overarching research question that was addressed in both projects was, how can we best facilitate the integration and routine use of electronically administered quality of life and healthcare experience assessment instruments as practice support tools in palliative care for older adults who have chronic life-limiting illnesses and for their family caregivers. And you'll note that below this question on the slide, there's a second question in light gray. And just because of the interest of time, we won't be addressing this aspect in our presentation today, but if you're interested at all, please feel free to follow up with an email to us. Next slide, please. Thanks. So this may be a familiar model to some of you. It's the Knowledge to Action Framework by Graham et al. And we drew on this work to frame our research within an integrated KT approach. So I'm just going to focus on the steps A through E, which are in light blue on the slide, and they'll provide just an overview of the design of the projects. So in A, identify the problem. This is the research question that I actually just read from on the previous slide. And moving to the left under B, so from a user-centered design, the QPSS was created based on input from clinicians and patients and family caregivers. And we consulted clinicians in focus groups and in interviews throughout the duration of both projects. And then we also interviewed patients and family caregivers at multiple points in time throughout the projects. Just moving up to C, as we began to design the QPSS, we assessed strategies for overcoming barriers and facilitating, fostering facilitators for routine integration with practice. And then just moving up in that framework to D, each site was consulted about what design features and implementation processes would support their goals towards a person-centered approach to palliative care. And then lastly, moving to the right to E, as this design and implementation unfolded, we qualitative evaluated the local processes for integration. So I'm not going to focus on F and G, but it's just important to note that these phases are a part of this approach. And I'm just going to provide a little bit more detail about some of these steps. Next slide, please. Thanks. So qualitative methods were very advantageous in working through the integrative KT phases. So recruitment of clinicians in both palliative acute and home care was through our team meetings, and identification of potential patients and family caregiver participants was through their clinician referrals. And I mentioned earlier that qualitative data collection was through both focus groups and interviews, and the number of each of those is identified on this PowerPoint slide. And then just for analysis, we drew on Sally Thorne's approach using interpretive description. Next slide, please. So for the 2 projects, we've outlined here the clinician participant demographics. So you'll see that their mean age was between 40 to 50, primarily female, predominantly nurses, but there's certainly a good representation also from physicians and other occupations, including spiritual health practitioners, LPNs, pharmacists, OTs, social workers, administrators, and so on. Next slide, please. And similarly, here are the patient and family caregiver participants for the 2 studies. So you'll see that the patients were a bit older than their identified family caregivers. There were more female caregivers, not surprisingly, and you'll see throughout there's a diverse ethnic mix as well as diverse country of birth for the participants. Next slide, please. So this is just a slide with an outline of how the QPSS was designed, implemented, and used as a support. And I'm just going to walk through each of these now in a little bit more detail. Next slide, please. So it's critical that selection of instruments is tailored to the local context. And Rick mentioned that he had led a previous CFN funded project as a knowledge synthesis identifying over 200 PROMs and PREMS used with older adults, and the link to that report is actually on this slide here. So based on this previous work and our understanding about PROMs and PREMS from this study, we had multiple focus groups with clinicians. And as identified in the IKT process, which I previously talked about, involving end users is a really essential step to achieve successful integration. So in these focus groups, we discussed which instruments were important for their various patient concerns. And in these discussions about these instruments, we had really important conversations about the use of tools for screening and providing direction for future follow-up assessments. And the clinicians identified the potential to link with clinical assessment, but that it's really important that these are not one and of the same thing. Clinicians also voiced concerns about not wanting to burden patients through use of these instruments. Next slide, please. So this is just a list of the assessment instruments that the clinicians chose to use in these projects. And the ESAS-R is a patient-reported visual analog scale, which is developed to assess common symptoms in palliative patients. And the e-QOL-R and the Quality-F were previously addressed by Rick. And then just lastly on this slide is the CanHelp Lite, which is used to assess satisfaction with care for both patients and family caregivers. Next slide, please. So what are the desirable features of a system like the QPSS? So there are 6 important aspects that I just wanted to briefly outline based on our findings. There's 3 on this slide and 3 on the next slide. So first, a user-centered design is critical to creating an interface that focuses on the experiences of all the users. And ideally, patients and family caregivers can use the system independently or with clinician aid if needed. So simplicity is paramount, and James really showed that very well in his video. One of the goals was to reduce or replace costs through integration with workflow, and this can be accomplished, for example, through the capacity to compare current assessment with previous assessment, or printing results at individual or aggregate levels. Next slide. And security is absolutely essential from a privacy point of view. Multiple strategies are in place to support this requirement, such as things like using dedicated tablets or secure apps and servers, a lockdown mode, so patients or family caregivers can only see their results. And the system is designed to be adaptable, meaning it can accommodate any instrument you can dream of, not just PROMs and PREMS, which is exactly what James was talking about. And the QPSS is available for full capture and use of data. It can be used for robust aggregation and analysis, as well as for full integration with electronic medical records or other databases. So in these ways, it's certainly innovative. It offers cutting-edge use of technology at the point of care. Next slide. So from these desirable features, the mechanism of feedback was identified by the clinician as an essential component for such an electronic system. So pragmatically, the first was reporting assessment results. So for example, graphic display, which James showed, ranking of concerns, assessment in real time, or printing capacity. And second, feedback is needed to link with current practice. So potential mechanisms may include intervention prompts or tracking of interventions over time. And we actually had numerous conversations with clinicians about when or how these might be useful in their local context. And just a note on that point that contextual influences are absolutely essential when considering or designing feedback mechanisms. And next slide, please. So clinicians offered many perspectives. At times they were contradictory about use of the QPSS and how it impacted their practice. So just for example, one clinician said, "I find it so impersonal. It's difficult for me to get a client to tell me, you know, do you feel your relationship with your doctor is very important? And are you satisfied?" In a way, it's a lot of juice to extract from a client, from the situation, so I go easy. But I see that it could be good for my practice to use it more. Another clinician said, "I have a client in his 90s. His wife said to me yesterday that she's finding it really helpful because it's like reflecting on his care and his situation, and then he's coming up with things that he hadn't made her aware of. So it's kind of enriching the level of care that he's going to get from his feedback." Next slide, please. So the quality of life assessment instruments provide an initial structure for holistic assessment, as well as capacity for enhanced communication. So one family caregiver said, "I found the questions were very easy to understand, and it was very easy for me to just read them on the tablet. And when I got used to not pressing too hard and using the light touch, I found it very easy to use. I'm very surprised." And then turning to their loved one, who was the patient, they said, "How do you feel?" And overall, I'll just comment here that patients and family caregivers commented quite favorably on the opportunity to provide information about their quality of life concerns and their experiences with the care that they received using the standardized quality of life assessment instruments. And while the clinicians had feared burden, this was not echoed by the patients or the family caregivers. And another clinician commented, "As a nurse, I tend to focus quite a bit on physical symptoms, but it's a really, really nice tool to find out what the other symptoms are that we're not able to pick up on, psychological, emotional, existential. So I felt that it's a great tool to use for patients and that we get to focus on those." Next slide, please. So given that our overarching goal was to facilitate integration of quality of life assessment instruments into routine care, it was really important that we study and address the challenges for uptake by clinicians. So one of the challenges that the clinicians experienced was working with technology. So examples included things like forgetting their passwords or losing their personal key fobs. So the fobs were used for secure access to data. Or other examples were forgetting that a tablet was on the charger in the office and not taking it to the home care visit, or just general integration of using a handheld device for assessment and follow-up. And then obviously being in wireless dead zones was an extreme challenge for obvious reasons. And hands down, the consent process was viewed as the most significant barrier to implementation. So the consent process was perceived to take time and energy that fatigued patients. They thought it stressed family caregivers, and it was viewed as a burden by clinicians. So in turn, clinicians were quite reticent to offer use of the tablets to patients or family caregivers. And clinicians agreed that integrating the tablets into routine practice would have been smoother without the consent process. And next slide. Thanks. So while the QPSS is intended to be a practice support tool, clinicians also needed tangible support for them to use it in practice. But some clinicians had difficulty seeing how the QPSS supported a holistic therapeutic relationship, which is really deeply valued in palliative care. And while some felt like the QPSS curtailed their relational use of intuition and experience, others felt that the system provided a broader lens, particularly to family caregivers. So to provide support, as the team, we offered in-person training with a developer. We had all team education seminars as well as on-site champions as resources. And now, at the end, we see that use of electronic quality of life assessment instruments can be seen actually as a competency. And listed on the slide are 5 examples of what this might look like. And in this case, these competencies relate to things like skills, knowledge, attitudes, and resources for use of QPSS in their local context. So I'm just going to end the discussion of the results now and pass the microphone back to Rick for some discussion.
Great. Thanks, Kara, for this overview of the two studies. Here we focus specifically on the qualitative aspects of the studies. There's also a quantitative arm of the studies. So I'm just going to take 2 minutes for the sake of time to highlight a couple of things in the form of a discussion. One has to do with the considerations surrounding implementation of this type of system in practice and in health services more generally. As mentioned, the QPSS project relied on principles of user-centered design, which is key, and integration was followed a knowledge to action process. So very much an integrated knowledge translation type of process that involved collaboration with all stakeholders. We also followed recommendations by the user's guide for implementing patient-reported outcome assessments in clinical practice, which is provided by the International Society for Quality of Life Research. You could find it directly on their website. And we've learned that these are important foundations, but we've also learned that these foundations are not sufficient for ensuring successful integration of technologies like the QPSS in clinical practice. So to complement existing guidelines, we propose 4 levels of implementation considerations that have kind of been interpreted from the many interviews and focus groups that we've had. And so we are considering here the user level, the local level, the institutional level, and the technical level. The user level considerations include ensuring that the benefits of using the QPSS are immediately visible to older adults, their families, and the healthcare providers. When we bring in a change in practice, people need to see immediate benefits. There's not much time and space to operate within a hypothetical world. And in addition, clinicians need education and support to enhance their competence and autonomy in integrating these types of systems in their practice. These findings are congruent with results from a recent literature review by Anne Jones Hardings and Higginson's group in the UK regarding implementation of patient-reported outcome measures in palliative care. So you can have a look at that. However, we recommend that with respect to user-level recommendations, the focus should be on building competence within the team regarding the use of quality-of-life assessment instruments. And the challenges really are with building that competence within the clinical team. We've not really experienced hardly any barriers with the patient or family caregiver users of the QPSS. And it's really needing to focus on how to integrate such a system in practice. In addition to this, we need to consider local level considerations such as shared framing of the objectives and goals, an ongoing consultation with clinicians and stakeholders, and a long lead-in time so that one doesn't just bring a system into practice but actually has quite a long lead-in time. There's institutional level considerations. I won't list them here right now, but one really needs to understand the institutional context, and every context is different. There's of course also technical considerations that were alluded to earlier, and particularly with respect to a desire to integrate these type of technologies with other existing technologies. So this is the last slide. And I just wanted to kind of put this back into the context of our overall QPSS initiative. We're now in the middle of a multi-site evaluation study of the QPSS that involves 9 home care sites, 6 in Fraser Health, 2 in Island Health, and Alberta Health Services. That's funded by the Electronic Health Innovation Partnership Program of CHR for 4 years. And we're also proposing a similar type of projects focusing on the acute care sector for older adults. We've already commented on ideas for proposed technological developments, so I won't go into that right now. But overall, our focus here is on finding ways of making the needs and concerns of frail elderly visible at point of care and at all layers of healthcare decision-making. So that includes administrative decision-making and the government-level decision-making. So I'll leave it at that and open it up for questions, answers, and discussion. We have a few minutes left for that. I'm going to end with this quote that I started with, right, from Gertes, who was one of the authors on the book called The Patient's Voice, and focusing on patient-centered care, and who wrote that our aim should be to find out what each patient wants, needs, and experiences in our healthcare system. I think in the context of older adult care and care for the frail elderly and their family caregivers, it's really important to take up this mandate. We hope that the research will be able to facilitate that. Thank you.
Okay, Rick, thank you. And Kara, thank you very much for your excellent and informative presentation. You have answered a number of questions already in the last few minutes, so I think we may have time for one or two. So the first question I have is, to what extent do you think we should be using standardized quality of life assessment tools in the care of older adults, especially frail older adults?
Right. Well, that's an excellent question, and our project is motivated by the idea that I believe we should be doing that. I think that without standardized instruments, you know, there's a risk that the person-centered part of the clinical assessment is purely guided by the clinician's point of view. But we need to make sure that and also the comfort of clinicians to engage certain topics, whereas the use of a standardized tool at least provides a starting point for ensuring that all the topics that are typically considered to be of relevance to older adults are touched upon. And of course then the clinician will need to take that further, but at least it's a starting point. So we've had a lot of discussion about this in our focus groups and interviews. And Kara, would you like to say more about this, or?
Yeah, sure. I just want to echo. I hear the concern in the question. In that, you know, I think for many times for clinicians, the concern is, you know, somebody may be too frail to engage with something like this, and certainly clinician expertise will come into play, and we're not in any way negating that. Obviously, that will guide. But we have heard from patients who are in exactly that position, and family caregivers. These are older adults who are frail, who have life-limiting illness, and they told us that it was beneficial. So we need to also take their word for it and follow up accordingly. That's all I'll say about that.
Yeah, thanks.
Okay, here's the last question before we sign off today. And how might the integration of an electronic quality of life assessment tool work in your practice or research?
I'm sorry, I missed the second part of the question.
How might the integration of an electronic quality of life assessment tool work in your practice or research?
Yeah, exactly. Well, that's in part what the project is really about, and we have some insights about that. I think for practice there is a need for routine integration. It doesn't work to have some, you know, service provider come in and do independent administration of these PREMs and PROMs if the goal is actually to really integrate it at points of care. And so that involves building competence within the clinical team of using this kind of information and embedding it right within in their care. We do have examples of that. The ESAS is one example. There is some history of use, and we have, of course, many examples from using clinician-reported instruments. There's huge amounts of screening instruments and tools that people use in their practice. So it's actually just not such a big switch to actually also including patient and family caregiver reported instruments so that their perspectives are made visible. So in terms of research and program evaluation, there I think there is much more of a need for systematic data collection that is really tied to design. Of course, there is merit to use data that has been collected at point of care as well, and that is in the administrative health systems, but observational data is, of course, always difficult to make strong conclusions on. And so for program evaluation, it may be, and for research, it is typically more desirable to have kind of an external and objective way of administrating these type of questionnaires. And ideally, one would want to link the two and find out how the two are, similar or different. So used in practice, similar or different in terms of the information collected from the use, that is the information that's collected in different ways. So, and I'll just say I really welcome further discussion and questions. I know we're out of time, and so feel free to email me or Kara. Happy to engage discussion.
Yes, and I think your emails are on the presentation slides that will be loaded to our website today. So thank you, Rick and Kara, for sharing your work and your experiences today. It was great. And thank everyone for attending today's webinar. Please, if you can, fill in the brief pop-up survey to help us improve our webinars, and hope you can join us for our next webinar on May 4th. That ends today's webinar. Thank you very much.